So starting with the physiology. During pregnancy, fetus is enclosed in the sac with surrounding amniotic fluid. So what is the role of amniotic fluid? The first and foremost, why do you think nature has created this fluid concept around the baby? Why is the baby floating always? Anyone? Very good. So fluid is very important from the perspective of giving space to the baby so that baby moves. It helps the organs to grow, especially lung maturation. Moreover, it gives it a sterile environment. There is thermal regulation and it acts as a shock absorption method. So there is a mechanical shock absorption by amniotic fluid. So these are the physiological role. And how is it regulated? It is regulated at 3 levels. The first is placental. So placenta controls the amount of the solute and the water transfer between the mother and the fetus. So that acts as a barrier. Then you have the inflow and outflow mechanism from the fetus, including urine production, baby swallows the amniotic fluid, and the intramembranous flow. Third and most important is the maternal influence, where the maternal conditions, the physiological conditions of mother, they affect the fluid balance indirectly by affecting the placenta and fetus. So 3 levels: placenta, fetus, and maternal influence. So these are the 3 levels where amniotic fluid is regulated. Okay. So start telling me the causes of decreased amniotic fluid. First and foremost, if you're doing the scan and you see the liquor is reduced, what should come to your mind first? Very good. So you'll ask the history of leakage. Does she have any leakage? Okay, good. And structural abnormality, most important. Very good. Excellent. So the first and foremost, oligohydramnios can be due to reduced production. Now production, kidneys. So fetal genitourinary anomalies is the first structural abnormality that should strike you when you see decreased liquor. Second is placenta might be insufficient, and then the baby can be of IUGR or SGR. But if there is acute decrease, everything was going fine, suddenly the liquor has decreased over a short span of time, you must ask history of leaking PV. In that case, PPROM can be there. So history is important. What about if the liquor is increased? What are the structural abnormalities that you will think of? And give me a good maternal cause. Okay. Yes, these are the important structural abnormalities. And the maternal condition is, yes, diabetes. So anything which impairs the swallowing of the baby or absorption of the fluid from the fetus is going to cause increased production. So there is reduced resorption, and that's why there is increased accumulation of AFI, the amniotic fluid. So it can be in cases of the GIT obstruction or any neuromuscular causes that is impairing the ability of the baby to swallow. Okay, so these 3 important things. And then maternal causes. Diabetes, very important cause of poly, and hypertensive disorders of pregnancy. Does hypertension cause polyhydramnios? Yes, no. If no, then it should not have been mentioned. If yes, you tell me why. How? What is the pathophysiology? Pathophysiology of hypertensive disorder causing oligo and poly. Let me know and we'll discuss. Okay. Meanwhile, abnormal amniotic fluid volume is a marker of a underlying either fetal pathology, placental abnormality, or a maternal pathology. So the moment you see an abnormal liquor, look for these 3 things and start evaluating in the form of checklist. Start checking for the fetus, look for structural abnormalities. Maternal, ask for histories and her conditions, and then the placenta ultimately. So amniotic fluid assessment is a critical component of every obstetric scan. Now, amniotic fluid production is gestational dependent. Now, this is important. You should know how it is produced at different gestation. Prior to 16 weeks of period of gestation, amniotic fluid is produced and maintained via the membranous flow. Okay, so it is the intramembranous flow which plays the role. Now it can occur across amnion, chorion, or the placental surface. So prior to 16 weeks, usually structural abnormality of fetus causing oligo is not seen because the amniotic fluid is being produced through the intramembranous flow. After 16 weeks, the kidneys mature and they start functioning, and then the fetal urine production starts, and it acts as a major contributor of the amniotic fluid volume. So now, if after 16 weeks there is an abnormality of the amniotic fluid, you know that there is something wrong with the kidneys. If it concerns the fetus, then this is the first organ that needs to be checked. After 34 weeks in the third trimester, the urine production undergoes plateauing. So when it plateaus, there is a steady state equilibrium, which is achieved at 34 weeks of period of gestation for the rest of the pregnancy. Okay. Now, amniotic fluid circulation happens via the fetus swallowing. There is pulmonary as well as GI absorption of the fluid, urinary excretion, and the movement of the fetus is going to cause displacement. And that's how the amniotic fluid circulates. So what is the role of fetal swallowing? The swallowing of fetus requires an intact neuromuscular development. So if there is any issue with the neural or the muscular component, baby will not be able to swallow, and there will be polyhydramnios. After the swallowing of the fluid, there is absorption in the GIT or the lungs, and occasionally it gets regurgitated also, and that's how the flow is maintained. Remember, swallowing and the fluid getting into lungs is very important for the canalicular branching and the alveolar development. So normal lung development is related to the amniotic fluid. So the fluid enters into the branching of distal alveolar buds of the baby. So that leads to the distension of the collapsed alveoli and they grow properly. If there is oligohydramnios, there is reduced alveolar branching, decreased number of alveoli, and these both will then contribute for pulmonary hypoplasia or immaturity. And that is why you see the babies with less liquor at an earlier gestation tend to have more mortality because of pulmonary hypoplasia. Okay, and that is how this physiology is related. So this recycling loop is very important, gets absorbed from the gut, enters the fetal circulation. This fluid will then, after getting absorbed, get filtered by the kidneys and then excreted as urine to reach amniotic cavity. So this is how the cycle is maintained. Movement will distribute the fluid within the amniotic cavity. So that's a loop. And if there is any break, if there is decreased absorption or decreased production, there will be change in the homeostasis and lead to different, picture, polyhydramnios or oligohydramnios. Now, besides the fetus, maternal and placental influences are very important. They're going to influence the osmolality. The blood pressure of mother is going to, change a lot of things, including the perfusion of placenta and eventually affecting the AFI. So now, could you make out how maternal hypertension is going to affect the liquor both ways? I think decreased liquor with maternal hypertension is easy to explain. Can anyone tell me how maternal hypertension causes oligohydramnios? Before we go into the imaging, then we will start the imaging component. Okay. Okay, very good. So we'll write here. Maternal hypertension is going to cause decreased, we'll start from spiral artery level. Spiral artery remodeling, right? So trophoblastic invasion and everything is hampered. That leads to uteroplacental insufficiency. Now, how do I know by ultrasound that there is uteroplacental insufficiency in first trimester scan? The mean PI of uterine arteries would be raised because of increased resistance. Now, the uteroplacental insufficiency is going to reduce the placental perfusion, leading to areas of placental infarcts and the areas where exchange is not getting well. Okay, now that will lead to fetal hypoxemia and hypoxia. Once the fetus experiences hypoxia, there will be a very important phenomena that leads to alteration or redistribution of the perfusion in the fetus with brain sparing. So you see MCA changes, and there is shunting of blood from the kidneys, right? So once there is reduced fetal renal perfusion, it will eventually lead to hypoperfusion of the fetal kidneys, decreased urine output, and that leads to oligo. I think it is very easy to understand why maternal hypertension is causing oligohydramnios. But the same maternal hypertension in few cases can cause polyhydramnios. So can you tell me how? If the maternal hypertension is mild, especially if it is in the earlier cases, mild and early cases of maternal hypertension with partial hypoxia in the fetus. Now, there are two, it's very rarely associated with polyhydramnios, first of all. It's always causing oligohydramnios. In some cases where there is an early set-in with partial hypoperfusion, it leads to partial hypoxia of the fetus. So this is one proposed theory where the fetus adapts. RAS system gets activated, leading to renal hyperperfusion, renal vasodilatation, very good. That leads to fetal polyuria. Yes, so the AFI will increase. That's one method which is proposed, how there will be polyhydramnios. The second thing is where there is poorly controlled hypertension. In such cases, the endothelial lining of the placenta gets dysfunctional. So the placental endothelium now is dysfunctional, and that leads to decreased membranous absorption. So that transfer that we discussed prior to 16 weeks is gone, and hence if absorption is decreased, it's going on accumulating, and that leads to polyhydramnios. Okay, just a small physiology. I hope it is clear. So maternal hypertension can cause, most of the time it causes oligo. It decreases the fluid because of the shunting of blood from the kidneys and brain sparing. But in some cases, with two proposed theories, it may cause polyhydramnios. Okay, clear? So now imaging, how to image the amniotic fluid. First and foremost that we all are doing is ultrasound. Complete obstetric ultrasound examination includes evaluation of the uterus, cervix, cervical length, internal os, and the adnexa. Then assess the placenta. So these are the basics. They need to be done in every case, irrespective of gestation. And along with that, fetal anatomic survey, including morphology and growth, biometry, both need to be done in every scan. You look for the fluid. So fluid assessment can be done qualitatively and quantitatively. It's very important. You do it both ways. The first is qualitative assessment, and qualitative assessment can be done by looking at the area which is occupied by the fluid and the volume which is occupied by the fetus and placenta. So need to have a visual comparison between these two things. In the early part of the gestation, the first and early second trimester, if the volume of the communicating intrauterine pockets of fluid is equal to or slightly greater than the volume which is occupied by the fetal parts and placenta, it's normal. You can understand it as if in the first trimester while you're doing NT-NB scan or the early second trimester, if another baby can fit into that cavity, qualitatively this amniotic fluid is adequate. Okay. So the volume occupied by the fetus and placenta should be almost equal then to the volume which is being occupied by the amniotic fluid. That is the qualitative assessment. It's very important in early trimester where semi-quantitative measurements don't work and they're not applicable, and in later gestation when you just want to have a global visual assessment. The semi-quantitative methods include amniotic fluid index and the deepest vertical pocket. It's very important. You should know both of them, how they are done. And after 20 weeks of gestation, either of these methods can be used to assess the amniotic fluid volume. Starting with AFI. Before doing any measurement, before turning on the caliper, take your probe and sweep through entire uterus to look for all the pockets that you can see. Just keeping probe on the lateral edges of the uterus will not help you. The uterus is to be screened fully. First visualize completely. Then you divide it into 4 quadrants. Okay. Your probe should be perpendicular, 90 degree to the surface of the maternal abdomen. And then you measure the maximum anteroposterior dimension in the largest pocket that you could see in that quadrant. Exclude the cord, exclude the fetus parts while taking this measurement. So see, this is the probe. Now it is held perpendicular to the maternal abdomen. Before choosing the particular pocket, I believe you have screened the entire uterus and you found this is the most reasonable pocket of fluid that can be measured. So once you see that, take the maximum anteroposterior measurement or in each of the quadrant, add them up and you get the AFI. It's as simple as that. So start measuring from the superficial edge to the deep part in that quadrant. Now that can be the part of the uterus or it can be the fetus. But remember, this is very important and often missed. The fluid pocket that you are measuring should be at least 1 centimeter wide. So if I'm taking this pocket, the width of the pocket should be at least 1 centimeter or more. Then only there is a benefit in measuring that fluid pocket. And once you have chosen such pockets, add them up and you get the AFI. In the deepest vertical pocket measurement, first of all, again, you will screen the entire uterus. You screened the entire uterus and you found this is the best pocket. So identify the single largest fluid pool and then measure it. Now, what is the difference between DVP and AFI measurement? The first and foremost is DVP can be there anywhere, especially central. So if you have a central pocket of fluid, you can use the DVP technique. In AFI, you tend to measure the quadrant, so you often miss the central part. So the pocket can be central in cases of DVP. Again, the inclusion criteria is same. Pocket should be at least 1 centimeter wide to be able to be included in the measurement. Now, what happens in severe oligohydramnios? There is not even a single pocket which is 1 centimeter wide to take the measurement. So, what to do in such cases? You will report it as severe oligohydramnios and few non-measurable fluid pockets were seen. There's no need to give a specific number in such cases because there is no measurable pocket. Less than 1 centimeter, don't measure it, otherwise you're going to overestimate the AFI. So DVP tends to overdiagnose polyhydramnios. AFI tends to overdiagnose oligohydramnios. Therefore, DVP is used for diagnosing oligo and AFI for poly. So now in this session, we are focusing on oligo. So our focus is on DVP. So what if you have twins? How do you measure AFI in twins? Anyone? If you have twins, you write the amniotic fluid is adequate. So do you use AFI or you use DVP? Anyone using AFI in twins? So we are using DVP. Very good. So DVP is used. AFI is not recommended for use for measurements of amniotic fluid in twins. So we have nomograms for gestation age specific AFI nomograms, but we definitely use the absolute cutoff these days. It is not widely used. These are the nomograms. Less than 5 centile can be used as the cutoff for oligohydramnios. We do have absolute value, which we will discuss. Now, role of MRI is very important in amniotic fluid assessment. Nowadays, MRI fetal is coming up. So when you're going to evaluate the detailed anatomy, then you can use the MRI to look for amniotic fluid as well. Now, where is the MRI used for looking at the morphology? First and foremost, if the mother is very obese, lot of soft tissue leading to poor acoustic window. If there is poor acoustic window, then you can justify an MRI. Or if there is severely decreased liquor, again leading to poor acoustic window, so MRI can be used. It's a problem-solving tool rather than a primary screening modality. Remember that always. Unlike ultrasound, we don't have a dedicated semi-quantitative method for measurement of amniotic fluid on MRI, so it's subjective and qualitative. Now we'll discuss the pitfalls, and it's very important because we are doing AFI measurements day in and day out in our clinics and hospitals, but we tend to misdiagnose. Okay, so first and foremost thing is always measure, evaluate, assess the entire uterus before picking the caliper. Because the moment the technique is everybody puts the probe, measures that pocket, measures, and you sum it up. No, look for the entire uterus, look for all the pockets that are feasible, that are measurable, give every pocket a chance to get measured, and then measure. Central pockets are also important, not just the periphery of the quadrants. Now, this is a measurement. Two measurements are there if you see carefully. One is the caliper and the second is the arrow. Which measurement is correct? So if you are asked to report this, which measurement will you be reporting in your or conveying to your clinician, and why? Now we have discussed how to do the measurement. I hope everybody is clear about how to do the measurement. So which one is correct and why? Very good. this one is A and this one is B. So are we reporting A or B in our report? B. Absolutely right. We are not reporting the caliper because first of all, the pocket is not the largest pocket in this picture. See, this entire is the pocket area, which is in pink. We are going to take the maximum anteroposterior measurement. So clearly this is not the maximum. So the arrow one, the second one, is the one which is the largest anteroposterior dimension available for us in this pocket to be measured. So we will give the arrow one a chance to be measured because it is the maximum. And this is the correct technique for measuring this fluid pocket. And we're discussing about this entire pocket. So take the maximum anteroposterior dimension. Simple. What about this measurement? They have done it in all quadrants. Anything wrong? Or is this measurement fine? Especially focus on this. Because in the fourth, they have not measured, it's 0 only. Absolutely right. If you see the width, none of the pocket is 1 centimeter wide. So this is overestimating AFI. This should not be AFI 6 because we don't have any measurable pocket. This measurement is wrong. So you don't have the width. That is why this measurement is not right. What about this technique? This is my pocket. And the measurement is done. Where is the measurement? This is the measurement. Is this technique correct? Or can we improve upon this? So yes, this technique is fine. This is the correct technique because the pocket width is 1 centimeter and we are measuring not here, we are measuring the largest anteroposterior dimension that is available to us in this pocket, right? So this is how the one quadrant should be measured. And if you're taking DVP, again, the parameters remain the same, 1 centimeter width at least. Then you can have some probe-related pitfalls. If you press too hard, then you are going to compress the pockets that will lead to underestimation. Then umbilical cord often misguides. So color Doppler, see all the pockets that we saw, they always had this color box on. So when you are measuring, color box should always be on. If you're just doing a 2D scan, you might measure this. The width is also good, anechoic fluid, but the moment you turn on the color, you know that there is no fluid pocket. This is a umbilical cord. So it's a pitfall. Always when you're doing a measurement of AFI, turn on your color. Always thorough search through entire uterus should be done before selecting the pockets. And then you can zoom in, zoom out. If you do over zooming, then either you can lose the context about the area that you are measuring, or you can incorrectly select the pocket. Now look at this pocket of fluid. We are trying to measure a single vertical pocket. Color has been turned on. Anything wrong with the measurement? Anything wrong with the measurement? Anteroposterior dimension is taken. There is no fetal part. There is no umbilical cord, nothing inside. So you have taken the maximum. The only problem in this is when you zoom out, you see that this is the fetus, there is no fluid, and this is the urinary bladder. So urinary bladder was zoomed and it was measured. So in such cases, always look for the uterus in entirety to look for the pocket instead of the zooming. If you zoom, you might lose the anatomic context. Okay, what about this case? They have turned on the color. No color is there. But do you see some septations? What if I give you a hint? This is a Turner positive fetus. Which area is being measured here? It is not amniotic fluid. Yes, they have measured the cystic hygroma, the nuchal edema they have measured instead of amniotic fluid. So anatomy needs to be assessed prior jumping onto measuring any anechoic pocket that you see. So distended fetal bladder or the nuchal edema, they are fluid mimics. So cystic hygroma, everything needs to be looked for. Then there are certain things like artifacts. So this reverberation artifact, this is very annoying because this reverberation artifact can be misinterpreted as a myometrium and can lead to false estimation. So you should know when is this artifact or true myometrium. Now in multiple gestation, if the intertwin membrane is not visualized, then it's a little difficult to assign the DVP. And if there is incorrect assignment, then AF interpretation is with errors. So how do you classify oligohydramnios? The diagnosis is clear. DVP less than 2 centimeters and AFI less than 5 centimeters. These are the absolute cutoff. Gestational age-wise, you can take it less than 5 centile for that gestation. But most of centers, they prefer this absolute cutoff. So DF, deepest vertical pocket less than 2 centimeters. Anhydramniosis, you're not able to see any measurable pocket of fluid. So if there is severe oligo or anhydramnios, there are very high chances of pulmonary hypoplasia, especially if you see it in mid-gestation. And that confers the baby poor prognosis. So oligohydramnios happens with two incidence peaks. First is 13 to 21 weeks of gestation. And in this time, it is mostly due to the genitourinary abnormalities. And the second is towards the end, 34 to 42 week gestation, and that's usually due to maternal causes and placental insufficiency. Now, the gestation at which you are diagnosing oligohydramnios also tells you what structural area should be focused upon. So if you are having an early peak, look for the kidney urinary bladder, and later on, it's usually placental insufficiency and the maternal causes. So ultrasound assessment of genitourinary system, especially in cases of oligohydramnios, is mandatory. Early onset is warrants that there is a clear evaluation of the renal and urinary tract abnormalities, and late onset you will look for placental function and the maternal factors. Whatever be the timing, whenever you are having oligohydramnios in your case, always do a comprehensive fetal anatomic survey and placental evaluation. Remember, amniotic fluid, irrespective of a kidney abnormality, even in cases if there is a unilateral renal agenesis or renal agenesis, up to 16 weeks, the amniotic fluid may be normal. Why? Why will the fluid be normal? Because of the membranous transfer and the AF production. The amniotic fluid will be normal up to 16 weeks. After that, the changes will set in. So oligo can happen in early gestation or late gestation. In early gestation, usually genitourinary abnormalities are the reason why there is oligohydramnios. So renal problems, renal agenesis, PUG obstruction, multicystic dysplastic kidneys, and autosomal recessive polycystic kidney disease. So these are the renal causes, and we're going to see each case. Then you can have the lower urinary tract problems in the fetus, like posterior urethral valves and prune belly syndrome. They will also have the same mechanism, obstruction. If the urine output is decreased, oligohydramnios will be there. Twin-twin transfusion is a case that is commonly seen in cases of the monochorionic multigestational pregnancies. Now that is something which leads to oligohydramnios. Later on, it's usually maternal placental factors like PPROM or insufficiency. Now, this is more important, so we'll focus on that. The same chart. Maternal hypertension, we discussed in detail how it leads to oligohydramnios. So there is uteroplacental vasoconstriction, there is reduced perfusion, so insufficiency and oligohydramnios. PPROM is basically due to the leakage of amniotic fluid. So once the fluid leaks, automatically the amniotic fluid volume is going to decrease. Right? Now it is diagnosis is clinical. Now if there is persistently reduced liquor or it's going on decreasing with history of leakage, you can diagnose it on ultrasound as well. Spontaneous PPROM is due to infection intrauterine, and iatrogenic happens if there was an amniocentesis or any fetal intervention done. So iatrogenically also the rupture of membranes can happen. Now, anywhere if oligohydramnios happens early, prior to 25 weeks of gestation or is prolonged, it confers a poor prognosis because the time for the lung development is reduced. Whereas if it happens after 25 weeks or is for a shorter duration, it gives improved survival to the fetus. Okay, so we'll start with the fetal causes of oligohydramnios. Fetal growth restriction, again, there is a redistribution of the blood flow, brain sparing and shunting of blood from the kidneys, leading to decreased urine output and oligohydramnios. You know how to diagnose IUGR? These are the Doppler changes, umbilical artery, Doppler. There is increased resistance, so decreased absent or reversal of end-diastolic flow. Brain sparing effect in MCA, so decreased resistance. There is umbilicalization of MCA color Doppler, and uterine artery might show increased resistance in form of raised mean PI. For placental morphology, you will look for the thickness, the morphology, shape, and where is the cord inserted. So now this is the case, the interesting one. So definitely the maternal and placental causes are relatively easy to diagnose. It's the structural abnormalities that include the litigation, the legal implications, and important from the perspective of treatment. Now this is a baby with axial image shown to you. This is coronal sag. Anything you can make out? What I can see in these images very clearly is the liquor is very reduced. See, there is approximation of the uterine walls, placenta to the fetus. I cannot see fluid. So if I cannot see fluid, I am worried about one organ, which is kidneys. Now start focusing. Now all images are focused on kidneys. Anyone? This is the axial image at the level of kidneys. We are trying to focus kidneys. So in axial images, I'm not able to see kidneys in the renal fossa. So took a coronal turn, turned on the Doppler. I don't see the renal arteries originating from the aorta, abdominal aorta. On sagittal images, the adrenals are not of Y shape as they should be. It seems as if they are lying down. Adrenals are resting against the paraspinal musculature. So what is the diagnosis? Bilateral renal agenesis. You don't see any fluid. So anhydramnios. Kidneys are not seen in renal fossa. Renal arteries are not demonstrated on the coronal plane and lying down adrenals. So basically when adrenals are growing, the kidneys give it an impression, so it becomes Y-shaped and it lies on the top of kidney, right? If there is renal agenesis, it keeps lying down in the paraspinal regions, and that is the lying down sign of adrenal glands. Now this is the picture of bilateral renal agenesis.